Super. Thanks very much for inviting me to talk. I'm John. I'm one of the infectious diseases microbiology consultants newly started at Barts, and I'm certainly glad to be here. These will be 3 cases that have arisen in the last year since I've been here, so there's no shortage of pathology, fungal-wise, in Barts Health. So rather than give you all a headache at the end of the day, this is the home straight. I thought a better title would be Head Cases from Barts instead. So we'll talk through 3 cases. There are some questions involved just to try and keep you awake, with hopefully some lessons at the end that we can take away. So without further ado, I'll go on to, no conflict of interest. Case number 1 is an 84-year-old man with a background of well-controlled diabetes who presents to the ENT clinic with a 5-month history of left earache, numbness over his cheek, and left-sided hearing loss and tinnitus. So very much an ENT presentation. He also reports 20 kilos of weight loss in the associated time. Let me go back. So ENT see him. They do some flexible nasal endoscopy and see some fullness around his left eustachian tube and refer him urgently for a scan, which shows that. So can anyone spot the abnormality? Just in case you can't, there it is. And in a coronal view, that's what it looked like. So I am, unfortunately, no neuroradiologist, and on my presentation I have a nice big list of notes in terms of what that's supposed to show, but I'll just suffice it to say that shows something that's not quite right in his left temporal lobe. So the working diagnoses were, given the history and the weight loss, there's clearly involvement, there's an otic source. This is probably an underlying malignancy. That was the working diagnosis, and the plan was to bring him in. Now, the first intervention that happened, I'm not entirely sure why, was a fiber optic endoscopic sinus surgery. So they went to have a look up his sinuses, presumably to see if they could see any evidence of malignancy moving its way forward into his sinuses. Now, there was no obvious macroscopic abnormality. His sinuses were biopsied, and on microbiology, which was very nice for them to send to us, there were no white cells seen. All samples grew Staph aureus, but fungal and mycobacterial cultures were negative. Histopathology showed no evidence of fungal infection, no evidence of granulomatous infection, and importantly, no malignancy. So we were really no further forward other than finding the Staph aureus. So the first question, who thinks this is Staph aureus infection in his head? Vote now, I think, when the groovy music comes on. Fantastic, very good. So we agreed. I'm interested to see that not so many people are here, but 9% thought that it probably was Staph aureus infection. So it's a reasonable thing to consider. We thought it probably wasn't. He then went on to have what we thought was probably a more logical initial procedure, which was to refer to neurosurgery, who went to undertake a temporal lobe biopsy. Now, fortunately, they also sent us lots of microbiology. So we have most of our neurosurgeons pretty well trained, so they are pretty good, especially where there's diagnostic debate. So several samples, 1+ of pus cells, no organism seen. 1 of the 2 samples grew Aspergillus at 7 days. And interestingly, on reculture, going back to the original isolate, when we tried to reculture it, didn't grow. So we thought, well, what's this about? So 16S was negative, mycobacterial workup was negative. Because we got that result, we did a serum galactomannan, that was negative. On the basis of this result, would you start antifungals, yes or no? Or I'd quite like to see the histology, please. Great, very good, agreed. So we weren't sure. So there was diagnostic debate in terms of the story was a bit odd. There was a real worry that he had an underlying malignancy. The Aspergillus was only 1 of 2. It didn't grow in reculture. We weren't really sure what it meant. So we thought, well, let's have a look at the histology. So the histology comes back as saying features of an abscess. However, Graham, Grocott, and Ziel-Nielsen were negative. No malignancy was seen, but as the usual caveat, could not be completely excluded. So now let's see if we can change people's minds. On the basis of the histology report, who now would start antifungals, yes or no? Just to keep you all awake, because it's the home stretch. Fine, okay, good. So we've changed opinion. There are still some people, 25%, who are not sure, 25% who wouldn't, so half of us would give them some antifungals. So on the basis of the histology, I'll come on to what we did, but in terms of if you are going to start as antifungals, if you are one of the 50% who are going to start, what would you like to start him on? Amphotericin, anakinocandin, itraconazole, voriconazole, or combination therapy? What I'm looking for is a even spread, saying that we don't really know. That's what I'm hoping we'll get. Oh, okay. Good. Fine, that's interesting. So, even split, and presumably more than one agent, just one or two shout-outs for what you'd like to combine together? Lots of things, because he's clearly unwell, he's got a big lump in his head.
You don't know exactly what you're treating?
No, not at all. We don't. Exactly. All we're going on is one culture that didn't come through, so we don't know. So we sat down, had an MDT. We thought this is possibly an Aspergillus infection with an abscess and osteomyelitis. I'm being slightly unfair. He did have more imaging that characterized things in more detail that did show he had bony destruction. He had some extension around one of his jugular vessels. So one of our neuroradiologists had a look and said he thinks this is probably more likely to be fungal. So he's quite persuasive, so we were persuaded. So likely Aspergillus, likely otic source, possibility of underlying malignancy, but can't, I think, not treat the Aspergillus. Unfortunately, the size of the lesion precluded any survivable neurosurgery in terms of the amount that would have required to remove that proportion of his brain would have meant that he would have been unlikely to survive. So he was started on voriconazole, and the plan was to treat him for a long time, and just to see how things went. So he started his treatment for a long time. Unfortunately, his symptoms progressed, and he was re-imaged. And I think you can tell, I didn't really need the pointer, do I? So the image on the left was in June. Several months later, things were much worse with the coalescence of an abscess. And in the coronal view is exactly the same. So really not making much progress. Interestingly, the abscess was re-aspirated, plus cells, no organisms seen, no fungal elements seen on our microscopy, and culture Aspergillus did grow after a week. Histopathology, again, showed an acute pyogenic abscess, but again negative for Gram, Grocott, and ZN, and no metastatic disease was seen. He then had some cytology, and the cytology of the abscess revealed that. So wall-to-wall Aspergillus, well, hyphae branching at 45 degrees. So interestingly, 2 bits of histology didn't show any Aspergillus hyphae, and aspirate on cytology showed that. So just interesting in terms of the discrepancy between the two. So I guess the next question to you guys is slightly unfair in that you haven't got some information, but in terms of why do you think things may have progressed in this man? So he's, in terms of his risk factors for invasive fungal disease, he only has well-controlled diabetes, that's it. So has it progressed because we've not debulked him? Has it progressed because he's been given voriconazole and that's not good enough? Is he progressed because he's got an immunodeficiency that we haven't yet diagnosed, a combination of the above, or something else? So please vote now. Yes, very good. Okay, agreed. So yeah, I think it's very difficult to tease apart why he will have progressed. I think almost certainly it's because we didn't debulk the disease in terms of trying to achieve success in that. Now, interestingly, I think in terms of thinking about the adequacy of his antifungal therapy, we have grown Aspergillus. We sent it to the reference lab in Bristol, and they returned a result saying, yes, it is voriconazole sensitive. So we gave him an agent to which it was sensitive. Was it the right agent, in inverted commas? So the IDSA guidelines for Aspergillus say for CNS disease, voriconazole is your first-line therapy because of CNS penetration. So we think we have right agent in that it's sensitive, right agent in that it's going to get into a CNS. but we probably didn't do very well by him in that these were his voriconazole levels. So his voriconazole levels, so he achieved therapeutic voriconazole levels when he was an inpatient with us. He was transferred back to his referring hospital. Always nice to pass the blame to somebody else when things go wrong. But he was fantastically subtherapeutic when checked 3 weeks into treatment. Lots of potential reasons why. When he came back, it was probably too late, and we got him back up to therapeutic levels. So this is one of the key take-home messages, is that this is probably one of the key reasons why he didn't, why things progressed. So it's ultimately is bad news, but initially he does well. So reaspiration and increased voriconazole levels, actually he survives and is discharged for rehab, being significantly debilitated following his long admission. Unfortunately, 2 months later from his nursing home, he's readmitted in septic shock with an E. coli bacteremia, likely urinary source, and unfortunately dies. On to case number 2 on that cheery note. But an important message, I guess, to bear in mind in terms of him. So a slightly quicker case, this one. So 74-year-old man, background of diabetes again, being his only real risk factor for anything fungal. His diabetes was less well controlled than the first case, and he was admitted via A&E, prompted by a 4-day history of an unremitting headache on a background of 4 weeks' worth of facial pain. So in terms of time courses, the first gentleman had symptoms for 4 months, explains the extent of his disease. This gentleman, 4 weeks of facial pain and 4 days of headache. And his CT, there's a nice arrow pointing to where the problem is. So in his frontal sinus, I think you can see he's got a pacification of his right frontal sinus. And imaging further up from his frontal sinus, again, the bars show you what we're trying to measure. He has a subdural empyema that tracks along his, essentially along his falciform ligament, kind of cribriform sort of plate, up between his hemispheres. So that's described as an abscess. And then a nice view in terms of a coronal view. That's his nice abscess sitting extradurally, so it's, subdurally, but it's not within his brain tissue. So that's an abscess. So then he goes for a combined ENT and neurosurgical approach. They send us, again, lots of samples, 7 samples this time, not just 2. So 7 samples, all had moderate numbers of pus cells, no organisms seen, no fungal elements seen by us. 6 of the 7 samples were negative bacteriologically, mycobacteriologically, mycology, and 16S. 1 of the 7 samples, which was from the ethmoid recess of his frontal sinus, had a light growth of proteus and a light growth of Aspergillus fumigatus. Same question. On the basis of this result, would you start antifungals? Yes, no, or can we see the histology, please? Fine, okay, so this one is, interestingly, that more than a third say, yes, let's just get on and treat. This is probably a bit more characteristic compared to the first case. So this is frontal sinusitis with extension upwards. Agreed, it would be quite nice to see the histology to see if it matches. And so that's the histopathology. It doesn't project very well at all, but there are, sorry, that's a H&E stain. There are allegedly fungal elements in there branching at 45 degrees, multiple septate hyphae. So again, suggestive of Aspergillus. So this is much more convincing. So now on the basis of the histopathology and the mycology, we've now decided to start him on antifungal. So he had been started on ambisome before we knew what the culture result grew. We thought, fine, he's got fungal sinusitis with intracerebral extension in someone who's got poorly controlled diabetes. Let's keep it broad in case it's one of the zygomyces. When we got the Aspergillus result, we narrowed things down to, well, we changed things to voriconazole. Again, discharged back to his referring hospital with clear advice about what to do about levels. Job done. Not really. So 6 weeks post-op, he's slow to progress, he's still got headaches, and he's got intermittent confusion. He's rescanned, and actually, it's post-operative, so actually the abscess is smaller, but I don't know if I've got a quick pointer thing, but actually, this bit here is an evolving area of cerebritis, so an area of evolving brain parenchymal inflammation, suggesting there is still ongoing infection in that site, possibly explaining his intermittent confusion. So things are not quite right. So again, same question as before. Why have things progressed with this chap? So is it, again, lack of source control? He's had an operation, but there's still some there. Inadequate antifungal therapy, an as yet undiagnosed immunodeficiency, or a combination of the above. So please vote now. Yeah, fantastic. I agree. So, I mean, I think he has had some semblance of source control, but there is still obviously infected material there. And again, in terms of his antifungal, Aspergillus, sent to the ref lab, Voriconazole sensitive, IDSA says use Voriconazole, so right agent, sensitive, Voriconazole levels. So initially, when the switch was made from amphotericin to Voriconazole, he wasn't loaded. There was no crossover period. He was just switched directly from, I think, even IV ambisome onto oral Voriconazole, so didn't achieve therapeutic levels quickly enough. When we noticed that his dose was changed, he was back to his original hospital, and the levels were down again. So again, the same message about the importance of measuring Voriconazole levels. So what to do now? Should we increase his Voriconazole? Should we change to another agent? Should we add another antifungal? Should we redrain the abscess? Or a combination of the above? And for those getting question fatigue, this is near the end of the questions, so don't worry. Yeah, exactly. So presumably, in terms of combination of the above, can I just have a show of hands? Who wants to add something to the Voriconazole? Fine, about a third. So shout out, what might that be? What would you like to add in? Amazon, so ambisome and Voriconazole, fine. Those who said do a combination of the above, who wants to keep the Voriconazole but go back in with the neurosurgeons? A bit more of you, about half of you. More than that, two-thirds. So two-thirds want to go back in and one-third want to add. And who wants to do all three? Who wants to add another agent and go back in? Fine, another third, fine. Super, very good. So what do? We increased his Voriconazole dose, so it was therapeutic, and the surgeons went in and redrained things. Last question, I think, how long do you continue the antifungals for following his second operation? 6 days, 6 weeks, 6 months, 6 years? It depends, largely on how he does and what his neuroimaging looks like and all the caveats with that. So please vote now. Yes, exactly. Fine, agreed. I think it depends on many things. He's clearly got worse despite our initial therapy. He needs to be followed clinically, neuroradiologically, and with multiple things. So there's no. It's difficult to draw a line to say 6 weeks we must stop. That's what you've had, or 6 months we must stop. So his progress, he has steady improvement apart from one setback, which is not fungal related. Who can spot the abnormality on that? If you can't, there it is. He falls over in hospital and breaks his hip, unfortunately. So this is not, I couldn't quite invoke a fungal element to this, or Voriconazole, unless he was a bit, I don't know. So fell over, broke his hip, unfortunately. But he was treated for a long time. We gave him at least 6 months of treatment following his second operation, and that's his repeat scan. So what you can see, the abnormality there is evolving encephalomalacia. So because of the cerebritis, it's never going to be normal. That's brain scarring, but there is no residual collection there. So the final short case, and short in a number of ways, 61-year-old man diagnosed March last year with AML, treated on AML 17 to complete remission, but relapses fairly shortly afterwards and treated on the RAVA trial with a combination of azacitidine plus or minus vorinostat. March 2015, comes into hospital with neutropenic fever. Blood cultures grow something called leptotrichia, which is an oral gram-negative, and it turns out he had gingivitis and 2 loose teeth. Fine, he's got an oral gram-negative causing his admission. 2 weeks into hospital, he's still neutropenic, he's got a bit of a grotty chest, and his sputum grows Pseudomonas. We treat him for Pseudomonas, that's fine. He's rehabilitating. He's now 4 weeks into hospital. He's still neutropenic, his counts haven't recovered, grumbling fevers, and now he reports a throbbing pain in his left eye with blurred vision. And he has a CT of his orbits. Now, it's his left eye. Now, I'm no neuroradiologist again, but what this, I think, shows is that side is normal, this side is not normal, and what they say is that there's thickening of the medial rectus and there's loss of the normal planes between the musculature. And the important thing is that. That's his posterior ethmoid sinus. That's normal. That's not normal. So that's full of gubbins, to use a technical term, in his posterior ethmoid sinus with involvement of the apex of the orbit. So we were worried. We think this is infection. Could it be pseudomonal? Could it be dentition from his manky teeth that haven't been taken out yet? Could it be fungal? So he was started on ambisome and piptaz. Started on piptaz because the soot he had from his chest was meropenem resistant, and is referred to ENT. ENT is not on the Barts site. The ENT is at the Royal London site, which is very far away, and it takes a very long time to travel between the two sites. So before he got his ENT review, days, he went blind, unfortunately. So 4 days later, before he had seen ENT, he lost his vision in his left eye and had a new headache that was just getting worse. So he was scanned. Now this just shows, I think this is an MRI rather than a CT. I think you can just see the back of the eye. You can see the proptosis of his left eye. It's much further anterior than the other one. And more worrying is he has a patch of cerebral edema in the patch adjacent, superior to the ethmoid sinus. So there's a bit of reactive change within his cerebral tissue on there. ENT see him and say he is too unwell and his platelets are too low for big surgery, for taking all this out from his middle ethmoid sinus, for taking out his eye. He is too sick, he is too unwell for that. He has a retroorbital biopsy. Histology shows chronic and acute inflammatory infiltrate, and past stains, I haven't got a picture unfortunately, show numerous fungal hyphae, multireceptate branching at 45 degrees, and microbiology grows Aspergillus fumigatus. So we add voriconazole to his amphotericin because he's clearly much sicker and we can't achieve source control. And now, unfortunately, just look at the time course. This is 2 days later. In 2 days, his eye goes from being a little bit out to a long way out. So just in terms of the proptosis, just compare his right eye with his left eye in terms of the asymmetry on that. And unfortunately, he has a fall on the ward, and he bleeds into what we think is a patch of fungal cerebritis in his brain, and unfortunately dies 24, 48 hours after this. And on that cheery note, just 3 points. I think these are 3 cases that have all arisen in the last year in the trust, and it just highlights some important cases of CNS aspergillosis. 1 is thinking about risk factors, 2 is about the diagnostic challenges, and 3 is treatment approaches. So very quickly, in terms of risk factors, immunosuppression, yes, what do we mean? So we mean neutropenia, neutrophil dysfunction, so diabetes, chronic granulomatous disease, corticosteroids, and other immunosuppressive agents. So in terms of the first 2 cases, the first case was interesting in that his only risk factor we could ascertain was a relatively well-controlled diabetes, so unusual. We had planned on doing a whole barrage of immunological investigations to try and work out, did he have an atypical form of chronic granulomatous disease that manifests late in life, but we never got around to doing that, unfortunately. In the second case, obviously, neutrophil dysfunction because of poorly controlled diabetes was likely the risk factor. And in the third case, likely prolonged neutropenia was the key sort of risk factor. But there are cases, obviously, following neurosurgery when you inoculate your Aspergillus directly following your intracerebral fiddling. And I guess in terms of diagnosis, these cases were challenging, the first 2 specifically, because especially the first couple of cases, they need multiple sampling to achieve the diagnosis. So in the first case, you remember, he had Aspergillus on 1 of 2 samples, 2 biopsies that didn't show any Aspergillus, and it was just on the cytology that we managed to get the diagnosis. And just highlighting the importance of microbiology and histology, and differentiation between lab contamination with Aspergillus, which is common, to true infection can be quite difficult. So in the first 2 cases, the Aspergillus took a week to grow, the growth was scanty, wasn't on all samples, it didn't go when we tried to regrow it, so just to highlight that. And interestingly, the serum galactomannan on all 3 cases was negative, which you might expect for them, given that it was limited to sinus and no pulmonary disease. There's some recent work in terms of what's the use of CSF galactomannan, published just in February this year, that shows that actually in people who you think have CNS infection, if you can get CSF, or presumably if you can get brain tissue, actually it's a reasonable place to go looking for galactomannan. We thought about sinuses. These people often get sinus washouts first up. I could only really find 1 study looking at the utility of galactomannan on sinus fluid, and that was only in people who they think have chronic fungal sinusitis. It's a very different group and that study didn't really show much utility, but with the caveat that they were looking at allergic chronic sinusitis. And in terms of treatment approaches, so the evidence and guidelines supports voriconazole with improved CNS penetration. Little evidence to support combining therapy other than they're not doing very well, add an additional agent. And factors that we know associated with a good outcome. The key is source control and debulking. So in a case series from, I think, MassGen, of 19 cases, the mortality in those, in a retrospective case look, those who had neurosurgical intervention and debulking or source control, the mortality was 30%. Those who had no neurosurgery, the mortality was 75 to 90%, so it makes a huge difference. The importance of an intact immune system, which we all know, but I guess more important, the importance of adequate voriconazole levels and the importance of an MDT approach. So the problem with cases like this is they move between different individuals, so your plan doesn't get passed over, and I think we haven't done that well, especially by the first two who kind of got a bit lost. So I'd like to thank the organisers for asking me to come and speak. Thank you for your attention at the end of the day. And if you've got any questions, happy to take them, or comments, and feel free to email me. So thank you very much.